Welcome to the workshop, CAR T-Cell Therapy in Acute Lymphoblastic Leukemia, Past, Present, and Future Directions. My name is Sue Stewart, and I will be your moderator for this workshop. Before we begin, I would like to thank Kite, a Gilead company, whose support helped make this workshop possible. It's now my pleasure to introduce to you today's speaker, Dr. Rawan Faramand. Dr. Faramand is a medical oncologist at Moffitt Cancer Center in Tampa, Florida. She specializes in blood and marrow transplantation and cellular immunotherapy. She's particularly interested in improving outcomes for patients with acute leukemias and myelodysplastic syndrome. Please join me in welcoming Dr. Faramand.
Thank you, Sue, for this kind introduction. I'm very excited to be here with you all today, and I'm looking forward to our discussion looking at CAR T-cell therapy for acute lymphoblastic leukemia, past, present, and future directions. These are my disclosures. For the presentation today, we'll first start out talking about acute lymphoblastic leukemia and the indications for CAR T-cell therapy, and provide an overview of what is CAR T-cell therapy. We'll talk about the patient's journey from the time of initial consultation to the time that they get the CAR T infusion and all the follow-up care, and also key issues for survivorship. We'll discuss both the short and long-term side effects following CAR T-cell therapy for acute lymphoblastic leukemia, and we'll wrap up talking about expected outcomes from this novel therapy and future directions. B, acute lymphoblastic leukemia is the most common leukemia among children. In fact, over 50% of patients diagnosed with ALL are under the age of 18. It accounts for about 25% of all childhood cancers in the United States, with an average age diagnosis of 17 years old. Fortunately, from the time that I started my fellowship training to now, we've had tremendous improvement in the outcomes of patients treated for acute lymphoblastic leukemia with novel immunotherapies. So now we have a 5-year overall survival of about 90% among children. One thing I'd like to point out is for this discussion today, we'll be focusing on patients with B acute lymphoblastic leukemia, since that's where we have FDA-approved CAR T-cell therapy products. It's also very important to keep in mind that there's a T acute lymphoblastic leukemia where there are some CAR T-cell therapies in clinical trials, but none that are commercially approved, so we will not discuss them for today's presentation. How about ALL among adults? ALL in adults is not as common. It accounts for about 20% of all leukemias in patients over the age of 18 years old. And although the outcomes have really improved in the past decade, the 5-year overall survival is certainly not as good as we observe in children. It's about 55% in adults as compared to 90% in children. Another important area of research is adolescents and young adults. As I pointed out on the prior slide, the average age of diagnosis is 17, and we know that there's differences in the biology of disease in pediatrics or children as compared to adolescents and young adults, and we consider anyone between the age of 16 and 39 to fit into that AYA category, and then adults over the age of 40. When we think of B acute lymphoblastic leukemia, we think of it in 3 buckets. Some patients carry the Philadelphia chromosome. You'll hear the terms BCR-ABL or Ph positive. There's also a Philadelphia negative B acute lymphoblastic leukemia, and then there's a Ph-like acute lymphoblastic leukemia. And that becomes important when we're trying to decide what is the best therapy and the expected outcomes for these different types of leukemia. It also helps us understand the differences in disease biology, because we're much more likely to see Ph-positive ALL in adults as compared to children, and we most commonly see Ph-like ALL among adolescents and young adults. So before we delve deeper into CAR T-cell therapy, I like to think back to immunology and back to our high school biology days and get a better understanding of what are T-cells when we talk about this therapy. So as cancer immunotherapy continues to progress and the science continues to evolve, we have a much better understanding of what our immune system can do to protect the body from threats such as infections or cancer, and know the importance of these T cells. The way that T cells work is they rely on the detection of antigens, which are found on the cell surface of abnormal cells such as infections or cancer, to help identify these as potential threats. In patients who are diagnosed with cancer, the T cells may not be able to recognize the cancer cells. So how can we use our own T cells to help them identify these cancer cells and be able to eradicate or kill these cancer cells? And this is where chimeric antigen receptor therapy comes in. The first part of this process is something called apheresis, which we're going to go over in a lot more detail in the following slides. This is a process in which the T cells are removed from the blood. We know that these T cells are unable to recognize the cancer cells, so these cells are then genetically modified with a core receptor, so I think of it like a GPS, so that we can help those T cells identify the cancer cells. For B acute lymphoblastic leukemia, we know that the cancer cells, the malignant B cells, express a target called CD19. So all commercially approved CAR T products are targeting CD19. You'll hear in different cancers that there are different targets that are used. These CAR T cells are then expanded in the lab, and then they're infused back into the patient. There are 3 commercially approved products for B acute lymphoblastic leukemia. The first one is tisagen laclusol. The other name is Kymriah, and this is approved for patients up to age 25 years who have either refractory or relapsed disease. And this was the first CAR T product that was ever approved back in 2007. So we're approaching 9 years of this approval, and that was based on the pivotal Ileana study. Brexacaptogene autoleucel, otherwise known as Tecartus, is approved for patients over the age of 18 with either relapsed or refractory disease, and that approval came in 2021 based on the ZUMA-3 clinical trial. And most recently, we have obacaptogene autoleucel, also known as Ocatzil, which again is approved for adults over the age of 18, and that was just approved in late 2024 based on the results of the FELIX clinical trial. As you can see, only one of these products is approved in children. The other 2 products are approved in adults. So in terms of the steps in CAR T cell therapy, I like to show the schematic, and we'll go over it in more detail in the following slides. The first step that you can see in the top left is the apheresis, in which we collect the T cells, and it looks very similar to donating blood. And there's a machine that looks very similar to a dialysis machine, which helps us collect these T cells. The T cells are then sent off to a manufacturing facility, depending on which product was selected by your treating physician. These T cells are genetically engineered, and then they're grown in the lab to proliferate. In the interim, the patient receives lymphodepletion chemotherapy, which allows the CAR T cells to expand in the body, and then ultimately goes on to receive the infusion. And for patients with ALL, this is going to be targeting CD19. So in terms of the patient journey, what can you expect? The first step of the process, of course, is the consultation, in which you meet with your clinical team to review indications for CAR T cell therapy. At that time, if you are a candidate for CAR T cell therapy, insurance authorization is submitted, and the product is chosen based on the patient and disease-specific factors, in addition to things such as manufacturing time. Once we receive the insurance authorization, the scheduling is completed for the apheresis process, and then it takes an average of 2 to 3 weeks for those cells to get manufactured. In the interim, the patient undergoes testing to make sure that they are in good shape and they're a good candidate for CAR T cell therapy. An additional therapy called bridging therapy may be needed at that time, and we'll go over that. And then ultimately, the patient comes in for the CAR T treatment that starts with lymphodepletion chemotherapy, which helps the CAR T cells expand in the body The CAR T cells are then infused and the patients are closely monitored. At the time of initial consult, one of the most important things is understanding what treatment the patient has had in the past, what type of ALL do they have. So we look at things like Philadelphia chromosome positive or negative or Ph-like disease. We luckily now have much more sophisticated testing that lets us know if there's very minimal disease that is in the marrow. That's called minimal residual disease. And then we look to see if the patient is fit, what other medical problems do they have, to determine if they are a candidate for CAR T-cell therapy. For all three commercially available products, they are approved for patients who either have relapsed disease, which means the ALL recurs after initial therapy, or ALL that unfortunately never gets into remission, otherwise known as refractory disease, after initial chemotherapy. And again, the type of CAR T-cell product that we use will be determined by the treating physician and will depend on both patient factors, but also things such as manufacturing time and also product availability, because not every treatment facility has access to all three CAR T products that are approved. After the clinical team determines if you would benefit from CAR T-cell therapy, and of course this takes into account the patient choice, so we do shared decision-making at that time, then insurance authorization is submitted. Before we start with the actual CAR T treatment, we like to complete tests to make sure that there are no active infections or other major medical problems that increase the risk of complications from CAR T-cell therapy. For patients who've had a prior stem cell transplant, they're very familiar with this process, otherwise known as vital organ testing. This includes imaging studies, typically a chest X-ray or a CAT scan of the lungs to make sure that we don't see any pneumonia or any problems in the lungs. We do an echocardiogram, which is a heart ultrasound, to make sure that the heart is functioning normally. And one of the most important things is getting a bone marrow biopsy done, in addition to a lot of blood work to look for prior infections, also called infectious disease markers or IDMs. The cells are then collected through the apheresis product, and apheresis is typically done in the outpatient setting. It may include the placement of a central venous catheter, which is an IV catheter that looks similar to a port, except it has a line protruding out of the skin, and that helps us collect the cells. Sometimes we're able to collect the cells just with a regular peripheral IV in the arm. The T cells are then shipped to the facility, which takes about 2 to 3 weeks to manufacture, depending on the product that is used. So what happens after the CAR T cells are collected and the apheresis process is completed? So while the CAR T cells are being manufactured, we may give additional chemotherapy. And one of the items I discussed in the prior slide is the importance of a bone marrow biopsy. The reason for that is it helps us understand how much leukemia cells are in the marrow. For patients with ALL, sometimes the marrow does not have any leukemia cells, but they have disease outside of the marrow called extramedullary disease. In that case, then we would also do a PET scan or a CT scan to look to see if there's any disease outside of the marrow. That might also include a lumbar puncture to see if there's any disease in the cerebrospinal fluid, which is the fluid surrounding the spinal cord and the brain. The reason that these tests are important is that we know that the amount of disease correlates with outcomes. So patients who have very little amount of leukemia cells in the marrow or in the extramedullary areas tend to have less toxicity and a better chance at achieving remission. So typically, if a patient has a lot of disease in their marrow or a lot of extramedullary disease, the treating physician may choose to give additional therapy, and that'll depend on what type of therapy the patient has had in the past, the subtype of their leukemia, and their overall medical fitness or well-being. So this bridging therapy is completed typically after apheresis and before the next step, which is lymphodepletion chemotherapy. After the T cells are manufactured and they're received back at the facility, then we give a different type of chemotherapy called lymphodepletion chemotherapy, which is given typically in the outpatient setting in a time period of 3 to 4 days. This type of chemotherapy is typically very well tolerated, and the most common lymphodepletion therapy that we use is a combination of 2 chemotherapy drugs, including fludarabine and cyclophosphamide. So why do we give this type of chemotherapy, especially as many patients would have just had bridging chemotherapy? The goal here is to help the CAR T cells expand in the body and prepare the body to receive the CAR T cells. So the name lymphodepletion comes from the lymphocytes, which are part of the white blood cells, which we're trying to eliminate prior to giving the CAR T cell therapy to allow those CAR T cells to really grow and expand in the body so they're able to kill the cancer cells. After the lymphodepletion chemotherapy is completed, the next step is the actual CAR T infusion. The CAR T cells are given through an IV catheter. It looks very similar to receiving a stem cell transfusion if you've ever had one, or a blood transfusion. And it can occur either in the hospital or in the outpatient setting, depending on the treating facility. And then most importantly, the patients will continue to get monitored for at least 30 days after the infusion. And each program has specific guidelines about local lodging requirements. Some of those guidelines are also coming from the FDA, in which some patients may need to be closer to the treating facility, live within an hour of the treating facility. This is also the time period where our program and the majority of programs will also require a caregiver, which means someone that remains with the patient 24/7 for at least 30 days. The caregiver is not required when the patient is at the hospital receiving treatment, but we do heavily rely on the caregiver when the patients are in the outpatient setting. For the next few slides, we're going to focus on CAR T cell toxicities. So what are the short-term toxicities of CAR T cell therapy? And I like to think of them in 3 separate buckets. The most common is cytokine release syndrome. The second most common is neurologic toxicity, also known as ICANS. And then we previously talked about CD19 and how CD19 is expressed on malignant B cells or cancer cells. CD19 is also expressed on normal B cells, and unfortunately, CAR T cells will not discriminate. So we eradicate some normal B cells, and that causes something called B cell aplasia, which impacts our immune system and can increase the patient's risk of infections. Because of this B cell aplasia, patients may also have low blood counts even beyond the first 30 days of treatment. And then we worry about other toxicity to other organs, which we'll review in the next few slides. So what are the risk factors for these immune-mediated side effects? I also like to think of these in 3 separate buckets. One is which CAR T cell product are we using, because they all have different toxicity profiles. Second are patient-related factors, such as the patient's performance status or fitness level and other medical problems that they may have. And third, which is tumor-related. So how many leukemia cells are in the bone marrow, and what is the subtype of leukemia, and do we expect that to be associated with more or less side effects? In terms of the timeline of when these toxicities can happen, typically the first week of treatment is when we're going to be giving this lymphodepletion chemotherapy, and we count the day of CAR T infusion as day 0. So everything that comes before that will be in the minuses. So for example, if chemotherapy is started 5 days prior to the CAR T infusion, that'll be known as day -5. Typically, during the few days of lymphodepletion chemotherapy, patients do very well, have very little side effects outside of some potentially nausea, which is very well managed with anti-nausea medication. On day 0, the CAR T cell product is infused, and typically we see the main side effects, which are cytokine release syndrome and neurologic toxicity, within the first 2 weeks of treatment. There can be delayed onset neurologic toxicity that can happen even up to 8 weeks after the CAR T infusion, but it's much more common for delayed onset neurotoxicity to happen for constructs outside of ALL, for example, for patients with multiple myeloma. There can be adverse events that happen after 30 days. Most of those are related to infection and low blood counts. So we'll first start out by discussing cytokine release syndrome because it's the most common side effect or toxicity of CAR T-cell therapy. It occurs in the vast majority of our patients, at 70 to 90%, and it can potentially be life-threatening. The reason this happens is because these T cells are very active, and when they identify the cancer cells and kill them, they can release a lot of cytokines or chemicals, and it causes a lot of inflammation, like an inflammatory storm in the body. This typically occurs within the first week of CAR T-cell infusion, and that depends on the construct or whatever product that we're using. Some can happen earlier, some can happen later. And we grade that as grade 1 through 4, depending on the severity of symptoms. The goal is to prevent this life-threatening complication while still making sure that the CAR T cells are effective. This is a schematic to show what can happen with cytokine release syndrome. So when patients get cytokine release syndrome, it typically presents with a fever. That's the first sign of cytokine release syndrome. When a fever happens, we also want to make sure that it's not related to infection. So we also do blood cultures, urine analysis, and imaging to make sure it's not an infection. And we typically start the patient on IV antibiotics. Once we determine that there is no infection, then typically we can safely discontinue the antibiotics in discussion with infectious disease specialists. But because there is this inflammatory storm, our patients can develop fast heart rate, known as tachycardia, or low blood pressure, known as hypotension. And we can also see impact on other organs, particularly when the blood pressure is very low. We can see impacts to the liver, which can cause some liver elevation, liver enzyme elevation, or some patients can develop respiratory distress or difficulty breathing. So how do we manage cytokine release syndrome? Typically, the management depends on the grade. So for patients who have a fever only, but no other main side effects, or normal blood pressure, no problems breathing, typically we manage that with supportive care, meaning things like Tylenol to control the fevers and IV hydration. For more severe cases, treatment includes anti-cytokine therapy. So with cytokine release syndrome, there's a lot of cytokines, such as interleukin-6, that can be released. And luckily, we have medications specifically designed to get rid of those cytokines, such as tocilizumab or anakinra. And we can also give steroids. For very severe cases of cytokine release syndrome, this may require additional support in the intensive care unit. Neurologic toxicity, otherwise known as immune effector cell-associated neurotoxicity syndrome, or ICANS, is the second major side effect in patients treated with CAR T-cell therapy. It's not as common as CRS, so it can occur in about 20 to 60% of patients, but it's particularly concerning to the caregivers or loved ones who are with our patients during this time period. The symptoms can include confusion, difficulty speaking. It may look very similar to a stroke, weakness, seizures, or very rarely, but a life-threatening complication of swelling in the brain known as cerebral edema. The onset of neurotoxicity can happen in various phases. It can sometimes occur concurrently with cytokine release syndrome, which is within the first week of CAR T-cell infusion. So typically when a patient has a very high fever, sometimes he can develop some confusion. So it could be more so related to the cytokine release syndrome, or it can occur after the cytokine release syndrome symptoms have completely resolved. And in some cases, neurotoxicity can happen weeks after the initial CAR T infusion. So how do we grade ICANS? We use a scoring system called the I-score, which you can see on the screen here. We ask patients these questions every single day, and then we grade them using the results of the I-score. When we look at grading the overall ICANS, we look at the results of the I-score, but we also look at other important factors such as level of consciousness, any seizure activity, any weakness, or any evidence of increased cerebral pressure or cerebral edema. And while this is a very scary symptom that can happen, of CAR T, and it happens commonly, the vast majority of our patients will completely recover from any neurologic toxicity. We do recommend anti-seizure medications for the first month of CAR T treatment to prevent that risk of seizures. And for patients who've had a prior seizure history or have ALL in the cerebrospinal fluid, sometimes we do ask our neurologists to see these patients prior to treatment, just so that they're well aware that these patients can have a higher risk of neurologic toxicity. It's also important to note that even patients who do have ALL in the cerebrospinal fluid, they've been successfully treated with CAR T-cell therapy in the commercial setting, and we have not actually seen a significantly higher rate of neurologic toxicity, so we know that this therapy is both safe and effective even in patients who have cerebrospinal involvement. Patients with mild toxicity can be managed with supportive care. In patients who have a more severe toxicity, we do sometimes do additional imaging, such as a brain MRI or a CAT scan and a lumbar puncture to rule out other neurologic problems. The majority of these patients who do develop neurologic toxicity can be managed with things such as steroids, and we can also use additional medications combating cytokines to treat the neurologic toxicity. So how common are these toxicities for patients receiving CAR T-cell therapy for ALL? It's important to note that these clinical trials had different scoring systems that were used for grading of CRS and neurologic toxicities, and may have had different management schemas, because some of the initial data with tisagenlecleucel, of course, is now over 10 years old. So as the science has progressed, there's been changes in both the identification and treatment of these toxicities. With patients treated with tisagenlecleucel, cytokine release syndrome was observed in 77% of patients, and about 46% of patients had a grade 3 or higher cytokine release syndrome. 40% of patients developed neurologic toxicity, with 13% of patients having a grade 3 or higher neurologic toxicity. For patients treated with brexacaptogene autoleucel, cytokine release syndrome occurs in 89% of patients, with grade 3 or higher occurring in 24%. Any-grade neurologic toxicity occurs in 60% of patients, with grade 3 or higher at 25%. Most recently, obacaptogene autoleucel was approved. For this product, cytokine release syndrome was observed in 69% of patients, but grade 3 or higher toxicity was low at 2%. Any grade neurologic toxicity occurred in 23% of patients, with grade 3 or higher toxicity occurring in 7% of patients. And while it's important to note that the vast majority of toxicities happen while patients are in the hospital, and most of these toxicities are cytokine release syndrome or neurologic toxicity, we're also learning about late effects and reasons why some of our patients unfortunately can die from a CAR T-related toxicity. Most of that is related to infections in about 50% of patients, but we also worry about organ toxicity, secondary malignancies, severe neurologic toxicity, or severe CRS. One other important item is that this pie graph is looking at all patients with CAR T-cell therapy and is not specific to patients treated for acute lymphoblastic leukemia. Infections are a very common complication following CAR T-cell therapy and can occur in 20 to 60% of our patients. And while the vast majority will occur in the first 30 days of CAR T-cell therapy, late infections can occur in about 20 to 40% of patients. So what do? We know that infections are very common. The best way to combat these infections is to put our patients on antimicrobial therapy to prevent these infections. That includes medications to prevent viruses. So we usually put our patients on a medication called acyclovir, and we also put our patients on an antimicrobial called Bactrim to prevent a specific lung infection called PJP pneumonia. Other approaches to prevent infections include using an intravenous immune globulin called IVIG to help boost the immunity, because we know that CAR T-cell therapy can lower IgG levels. We also recommend vaccines to prevent infections with the caveat that we're still learning about the efficacy of vaccines following CAR T-cell therapy. A lot of this data we extrapolate from the transplant literature, since transplant's been around for a lot longer than CAR T-cell therapy, and this is an area of active research where we're still trying to learn what is the best approach to prevent these infections. Each program may have specific recommendations, so these are can be generalized recommendations, but can also be program specific. Typically, at our program, we recommend that patients can return to work or school 6 months following CAR T-cell therapy, but of course, that depends on patient-specific factors and how well they're doing after treatment. In terms of long-term toxicities, so as we've been able to cure more and more patients with CAR T-cell therapy, we have a growing need to understand survivorship in this patient population and learn a lot more about late effects. So some of those areas of research include understanding the financial burden or financial toxicity of CAR T-cell therapy in the long run, also understanding how CAR T-cell therapy can impact things such as mood and fatigue. We're trying to understand any late effects of neurologic toxicity and understanding the development of hyperkinetic movement disorders, which are much more common in patients treated with CAR T-cell therapy for multiple myeloma. Infections, like we talked about, prolonged cytopenias or low blood counts following CAR T-cell therapy are common, and we're learning a lot more about therapy-related secondary cancers, such as development of AML or myelodysplastic syndrome following CAR T-cell therapy. There are specific needs that are unique to various patient populations, and one of those needs that I'd like to highlight is in adolescents and young adults and understanding fertility and sexual health needs following CAR T-cell therapy. We did complete a small study here at Moffitt Cancer Center. It included 13 AYA patients, and we evaluated their sexual health, health-related quality of life, and the way they communicated about their sexual health needs with the healthcare providers. We learned about 3 common themes. One is that young adults perceived a lack of healthcare provider awareness of the importance of sexual health to this patient population, that there was a lack of healthcare sexual health communication and information about what they should do following CAR T-cell therapy. And one of the barriers to asking questions and learning more about sexual health and fertility post-CAR T is that many of these patients had their parents as their caregivers. We also identified that the average interest in sex was lower for females but not males. Females reported worse fatigue, more impaired social function, and worse emotional experience following CAR T-cell therapy. And most of our patients did not recall discussing any sexual health needs with their healthcare provider either before or following CAR T-cell therapy. With the help of the Leukemia Lymphoma Society, we are conducting a trial, which is going to be a patient-facing survey to really understand more about fertility following CAR T-cell therapy, if patients were provided with any type of fertility education or resources, and for those patients who wanted to grow their families, if they've been successful in conceiving following CAR T-cell therapy on their own or with the assistance of reproductive therapy. So that survey should be up, and if you want more information about that, you can email pact@lls.org. So since we talked about toxicities of CAR T-cell therapy, for the next session of our presentation, we'll be talking about expected outcomes following CAR T-cell therapy. As we discussed earlier, tisagenlecleucel was the very first CAR T product that was approved, and this is specifically for pediatrics or children and young adult patients up to age 25. We already know the data from the Ileana study. That was a pivotal clinical trial, but it's also important to look at real-world data and get data from treating facilities across the U.S., which is where the CIBMTR comes in, and this is looking at data from 73 centers across the U.S. We saw that 55% of patients developed cytokine release syndrome, but only 16% had a grade 3 or higher or more severe toxicity. In terms of neurologic toxicity, this was seen in 27% of patients, and about 9 to 10% had a more severe neurologic toxicity. At the 12-month mark, 52% of patients were alive without evidence of relapse disease, and at the 12-month mark, the overall survival, the percentage of patients who were alive was 77%, and it's important to note that about 16% of patients did go on to receive a stem cell transplant. It's also important to know that many of these patients who received CAR T-cell therapy had already had a prior stem cell transplant as part of their initial treatment. Roxacabtagene autoleucel was the second product that was approved based on the ZUMA-3 study. In this product, 73% of patients were able to achieve a remission, and the overall survival was 71%. There was a recently updated analysis that was presented last year, which showed that the average survival is about 25.6 months, and in those patients, the patients who achieved remission, their average survival was 47 months. The most recently approved product is Ocabza, obacabtagene autoleucel. So one important thing to point out is this product is given in 2 infusions, and they're separated out by at least 1 week. And the starting dose of the cells depends on how many leukemia cells are in the bone marrow prior to the start of lymphodepletion chemotherapy. More than half of patients treated on this clinical trial had a prior stem cell transplant, which is very similar to the other products that are approved. And the oldest patient treated here was 81 years old. The average leukemia cell count was about 40%, and 23% of patients did have disease outside of the bone marrow. With an average follow-up period of about 22 months, 78% of patients were able to achieve a remission with an average event-free survival, so how many patients don't have relapse disease and are alive, of about 50%, and an average overall survival at 1 year of 61%. So we know that we have 3 commercially approved products, one that is only approved for patients who are pediatrics or young adults up to age 25, and overall across those 3 products, we have excellent initial response rates. But where we're focusing on in research is how can we improve the response rates and the durability of response to decrease that risk of relapse that can still occur following CAR T-cell therapy. So what happens after CAR T-cell therapy is completed and our patients achieve a remission? You saw across the 3 products, the vast majority of patients will respond to CAR T-cell therapy. Some of these patients may require a stem cell transplant. There are ongoing trials, mostly in the pediatric space, to look at to see who can benefit the most from stem cell transplant after CAR T-cell therapy. So this is an area of active research where we don't have all the answers yet. We're trying to identify if some patients can be treated with CAR T-cell therapy alone and potentially be cured from their leukemia, or if patients still require a stem cell transplant following CAR T-cell therapy. It is very important after CAR T-cell treatment to continue to check in and get monitored with your treatment team to look for things such as infections and to continue to monitor for relapse. I will say that the future is very bright for patients with acute lymphoblastic leukemia. In the past decade, there's really been a shift in the way that we treat patients with ALL, and luckily there's been several new therapies that have been approved for patients with ALL. Where is the future of research? There's many things going on, and we can spend many hours talking about that, but there are specific approaches that are getting studied right now for CAR T-cell therapy. One is using healthy donor T-cells. These are called allogeneic CAR T-cells or off-the-shelf CAR T-cells that would be readily available. A different approach is using 2 or more antigens instead of CD19, which is the main antigen that the commercial products are approved for, and developing new CAR T-cell products that might be able to persist longer to hopefully decrease the risk of the disease coming back. There are ongoing trials in identifying which patients can be treated with CAR T-cell therapy alone versus which patients may benefit from a stem cell transplant. And we're also looking to see if using CAR T-cell therapy as an earlier line of therapy, so using it up front or for patients who have minimal or residual disease, might translate to better outcomes in the future. So we're very excited about all the science that's going on to hopefully continue to improve outcomes for patients with acute lymphoblastic leukemia. And with that, I'm happy to take any questions. Thank you so much for attending this session.
Thank you, Dr. Faramand, for a very comprehensive look at CAR T-cell therapy for ALL. We'll start our question and answer session now. Excuse me. If you have a question for Dr. Faramand, please use the chat box and type it in on the left side of your screen, and we'll try to answer as many as we can. Our first question is, for how long do CAR T cells survive in the body?
That is a great question. We don't know the full answer to that. We know that they can survive for months to years following CAR T-cell therapy, but it depends on the product that is being used. And we don't have any commercial assays or blood tests that after the patient is treated with CAR T-cell therapy to know if the CAR T-cells are there. So it is an area of active investigation, but we know that they can last a long time.
All right, we have a couple of questions from caregivers. The first one is, what are some indications that CAR T-cell therapy is working? Is this something a caregiver could identify?
That is a great question. Unfortunately, there is nothing that would tell us if CAR T-cell therapy is working outside of a bone marrow biopsy or imaging scans. But the caregivers have a very important role to identify any side effects of CAR T-cell therapy.
All right, thank you. This person wants to know whether infections after CAR T-cell therapy are more common or more severe compared to the kinds of infections one gets from an allogeneic stem cell transplant.
That is also a great question, and that's another area where we're learning more and more. It seems to be similar in terms of severity for patients who received a prior stem cell transplant.
Interesting, okay. How long will a patient's immune system be compromised after CAR T-cell therapy?
That is also an excellent question. So we know that the area where the timing of the immune system being weakest is typically within the first 6 months to a year of CAR T-cell therapy. There are some blood tests that we can do that are surrogate markers to help us identify if there's anything we can do to boost the immune system. So we do recommend checking blood work for IgG levels, for example, and then we do recommend providing IVIG to help boost those immunoglobulin levels to improve the immune system, the ability to fight infections.
All right, the next question is, for how long is a patient needing a 24/7 caregiver, and what specifically are the caregivers expected to do?
Sure. So we do recommend a caregiver until day 30 of CAR T-cell therapy. And the main thing that we're expecting from the caregivers is to identify any cytokine release syndrome. So if there's any fever, to bring the patient into the treatment center, or if there's any evidence of neurologic side effects such as confusion, difficulty speaking, just someone really not acting like themselves. It can be very subtle changes for the caregiver to call the treatment facility and bring the patient in. For many products, we don't allow patients to drive for about 8 weeks following CAR T-cell therapy because of the risk of delayed neurologic toxicity. So we do rely on the caregiver to be able to drive the patient, help with medication management, and alert the treatment team for any side effects.
Got it. All right, this person wants to know if your clonoSEQ result is 0 and you had a brief relapse in the lumbar fluid, should you go early to CAR T-cell therapy?
So that is a great question, but I'd say it's more of a clinical question. So it really depends on what prior treatment the patient has received. So that's something that I would encourage them to discuss with their treatment team. We know that CAR T-cell therapy can be effective even in patients who only have CSF disease or patients who only have extramedullary disease.
All right, very good. This person wants to know, why isn't CAR T-cell therapy available to patients with other types of leukemia, like AML?
That is a great question. So in AML, we have a more difficult time identifying what that perfect antigen is. For patients with ALL, we know that CD19 is expressed on those leukemia cells, but for patients with myeloid leukemia, such as AML, we have a lot harder time identifying what that perfect antigen is. And so far, we've not been able to identify one that works across the board. So there are several CAR-T trials for patients with myeloid diseases, but none that are yet commercially approved.
All right, and along that same line, this person wants to know, have there been any positive reports about CAR T-cell therapy for solid tumors like breast cancer?
That's also an excellent question. There are different types of T-cell immunotherapy that has been evaluated for patients with solid tumor, but we don't yet have any CAR T-cell products that are approved for patients with breast cancer or GI cancers, but they are getting evaluated in clinical trials.
All right, this person wants to know, how long do the CAR T-cells remain in your body, and do they have to stay in your body in order to keep you in remission?
Sure, that is also an area of active investigation. So we know that there's some patients who still have CAR T-cell persistence, and that's being studied just in a research setting, but have unfortunately disease recurring. And we know that there's other patients where we can no longer detect the CAR T-cells, but the patients continue to be in remission. So that's a question that I don't have the full answer to yet. We're hoping to be able to answer that question in the next few years with ongoing research studies.
Great. Next question. You mentioned that there might be medical problems that a patient might have prior to CAR-T that would preclude them from going to CAR-T. Can you expand on that and talk about what kinds of medical problems might make them inappropriate candidates for CAR-T?
Sure. So that's a great question, and it really depends on the treatment facility. For example, at our institution at Moffitt Cancer Center, we don't have a specific age cutoff for CAR T-cell treatment, but I know some other centers may have an age cutoff. Mostly, we're looking to make sure that the cardiac function is good, so no history of really severe heart failure. We also want to make sure that the respiratory status is good and that patients are not on oxygen at home. But those are not set in stone, so it's always a risk-benefit discussion with the patient and looking at them as from a holistic lens and not like one specific thing that would exclude patients.
Understood. We have one more question, and again, if you have any questions, now would be the time to chat them in while Dr. Faramand answers this question. How do you make a decision between going to a stem cell transplant versus CAR T-cell therapy first?
Sure. So stem cell transplant is most effective in patients who don't have any evidence of ALL. So we use it as a consolidation therapy for our patients who are in a really good remission. And we use several studies or tests to really make sure that there's no leukemia at all. And some of these tests are called minimal residual disease testing, to see that even beyond just looking under the microscope, that there's no leukemia cells at all. We know that patients who are in a really good remission prior to the stem cell transplant are the patients who do the best following stem cell transplant. CAR T-cell therapy is used for patients who have relapsed or refractory disease, so the indication is a little bit different. So for CAR T-cell therapy, typically we use that for patients who have some evidence of leukemia cells either in the marrow or outside of the marrow.
All right, and one more question. If you're trying to choose a CAR T-cell center, what are some of the factors you should consider? Does the number of procedures that they do make a difference in terms of outcome?
Sure. So I think it's important to go to a facility that has a lot of experience with CAR T-cell therapy. So I would want to make sure that they've been doing CAR T-cell therapy for a while and have the expertise to manage these side effects. But I'd also want to make sure that it is a facility that is close to home and that is manageable for the patient to continue to follow up and be able to remain in the area close to the CAR T-cell center, because it's very important to have long-term follow-up even after the CAR T-cell therapy is administered. And that's where we form these collaborative relationships with our community oncologists, because many times our patients have to travel for CAR T-cell therapy, but then we continue to work with their oncologists in the community to make sure that they're getting the best care, even without having to come to the treatment facility as often.
Great, great. All right, well, that is the end of our list of questions. You were very thorough in your presentation, so I'm sure people had some questions that were covered in your main talk. I want to thank you, Dr. Faramand, for a very helpful presentation. And I also want to thank the audience for the excellent questions that you asked during this presentation. If there's anything BMT InfoNet can do to assist you, please don't hesitate to contact us. And I hope you enjoy the rest of today's symposium workshops as well as the rest of them during this week. Have a great day.